My name is Walid Shalib. I'm a medical oncologist here in Atlanta. Thank you for the invitation. I'm going to talk about quality of life of neuroendocrine patients. And I'm going to welcome you being in Atlanta over the weekend. So these are my disclosures. Majority of them don't apply as I moved from Emory to Wellstar. So the objective of my talk is to talk mainly about quality of life. And I'm going to twist a little bit out of medicine and show you how things from medicine go to quality of life and affecting people who are not here and people who weren't able to be here and people who are not able to have access to care and how much it impacts you as patients to have access to care or not to have access to care. So I'm going to describe the importance of quality of life, and I'm going to say what are the factors that affect the quality of life, and how to broach the topic of quality of life with your doctors, and then how to address some key issues which affect your quality of life as patients. So these are the predictors of quality of life. And these have been studied and are published. Pre-treatment quality of life, patients might have symptoms without knowing what these symptoms are. And as the previous speaker said, the patient might see 200 doctors before they come to a diagnosis of a carcinoid heart disease. And I'm sure majority of you have symptoms before they saw a doctor. You see one doctor, you see a second doctor, you see a third doctor, but you don't have access to somebody who knows about this disease, and the clinical probability that this is a neuroendocrine tumor might get delayed, and your diagnosis gets delayed, and the cancer progresses in the meantime. Patient characteristics, age plays a role, race plays a role, sex plays a role, and socioeconomic status, which is a big deal. Tumor-related characteristics, where is the tumor? This is what we call primary site of the tumor. That makes your quality of life to some sites of cancers more important than other sites. What I mean by that is, let's say a patient has a pancreatic cancer, the symptoms are different than patients who have small bowel cancers. Carcinoid syndrome, for example, is more common with small bowel, with intestinal cancers, neuroendocrine location, as compared to, let's say, pancreatic cancer, which can present with obstruction, with biliary obstruction, and the surgery is different, and the quality of life is different too. Treatment-related characteristics, depending where you are on the treatment. If you are on shots, it's different than when you are on Captem, which is a chemotherapy, versus targeted therapies, which can hurt your liver and can hurt you, and it might take time for a patient to recover. And then health behaviors, smoking and alcohol use are predictors of poorer quality of life. Symptom burden. Patients who are symptomatic, you have carcinoid syndrome, your quality of life is worse than patient who doesn't have carcinoid syndrome. And I was asked when I came here today, what is a functional cancer? A functional cancer is a cancer that secretes these hormones and affects you by giving you symptoms, and these symptoms are going to affect your quality of life from all angles. Angle number one, if you're having diarrhea, let's say, you need to identify a bathroom. Your diarrhea is more frequent. I see patients 25 times diarrhea. If I want to think about 25 times diarrhea a day, I would think, like, are we living in the bathroom or not? And these patients are not well managed because they didn't see a NET specialist. And this diarrhea could be related to treatments. This diarrhea could be related to carcinoid syndrome, to surgery, to the location of the cancer, to even obstruction that can present with diarrhea because it's a bowel obstruction and the stools are going to pass and there is no control on the stools. I want to get these ideas to the extreme. I know it might not be an extreme symptom, but I cannot imagine a person who has, let's say, 12 times diarrhea going to work and be productive and make money and has insurance and then go to a doctor. That's the difficulty of what we are addressing here. And I don't see it, unfortunately, when I look at the television and I see Mr. X running for Senate or House, and you've seen it over the past week. I see ex-wives crying, but I don't see anybody addressing cancer care. I don't see anybody addressing transportation. Patients don't have means to get to a doctor. Even when they have insurance, they don't have means, they don't have a car, and nobody is addressing that. So I want to touch on these issues more than how the diarrhea happens and how to treat it, because I think the previous speakers all through the two days, they've been talking all about it. Any case, comorbidities affect care, financial toxicity, which is what I'm trying to identify in this talk, and then psychosocial toxicities and the indirect cost. So these are the pathways that we try to target. Some of them we were successful in targeting, and some of them are under clinical studies. And you've heard Dr. Cohn talking about clinical trials, and we encourage patients to be on clinical trials so that we can develop more hope from treatment perspective. But even if there is a drug that is approved, and it is a new drug, number one, the price of the drug, is it going to be approved by your insurances? Are we able to afford the side effect of the drug? Are we able to go to the doctor to assess its functionality? Am I able to pay the co-payment of a scan? And I don't see this being addressed, neither at the national level, nor at the Senate, and nor even between our talks. We might develop a new drug, but it's costly. We might not be taking it. So when we develop clinical trials, I was a clinical trialist and still is, we develop quality of life questionnaires. And these quality of life questionnaires, some of them are standardized, some of them are not standardized. And what I mean quality of life questionnaire, you ask the patient, like, how are you feeling? Today, the patient might be feeling good. Tomorrow, he might not be feeling good. So even these quality of life questionnaires have some downsides. And the patient would remember what happened today and would forget what happened yesterday. And it depends on what is today, then the questionnaire reflects about what he feels today. So these quality of life questionnaires, although we carry a lot of their analysis and how they are interpreted, but basically majority of them have some patient bias and recall bias, but we need to have some sort of a questionnaire to follow. So basically, it is difficult to define what the symptoms today are, or yesterday, or over a month, but we need to have a focus to start with, and this is what we say, health-related quality of life, and here you see it, HRQOL, which is widely used to assess outcomes, and I'll talk about the EORTC questionnaire, which is used in neuroendocrine tumors. But there are other questionnaires that if you enroll in clinical trials, the clinical trialist will hand you these questionnaires and will tell you, okay, if you can fill it so that we can analyze the data on a monthly basis, on a 3-month basis, or even on a weekly basis. Majority of these questionnaires are now apps, so you might download an app and then put the symptoms or how you feel. Their clinical meaningfulness is very important, but to think about their applicability is going to be a little bit hard. What do I mean by these questionnaires? I put a sample, and this is one sample that I used during clinical trials. So the patient would fill the initials, date of birth. Usually it is non-identified, because if you're going to analyze the data, you don't want to identify the patient. So question number one, let's say, do you have any trouble doing strenuous activity like carrying heavy shopping bag or a suitcase? So general terms, it might not reflect what the patient can do or what cannot do, and there is a scale of 1 to 4. And then there is another one, trouble taking a long walk. For me, like, what does a long walk mean? A long walk could be 1 mile. A long walk to another patient could be half a mile. So although these are not standardized, but we use them. And then these are specimen sample that I put. I cannot use, like, I have to get the authority of the ORTC to use the whole thing. But let's say, were you limited in doing either your work or other daily activities? Were you limited in pursuing your hobbies or other leisure time activities? I mean, these are very important to address, and some of them we don't address it in the clinic because we try to rely on the patient to tell us what to do, what to know. And please, when you see your doctor, please write them, even if you don't, even if you think that you're going to tell the doctor about it, write them, and there is no question that is a wrong question, or please address your symptoms, because your symptoms are very important and we can help you. So what are the factors that affect the quality of life? Anxiety. And the anxiety is not only for stage 4 patients, it's anxiety that a patient who had a resected cancer, the anxiety of the cancer recurring. And this anxiety is hard to get rid of. I'm a doctor, and I always think, okay, I have a pain. Is it cancer pain or not? And I think it is affecting our lives as doctors, and I'm sure it's affecting you as patients. How about disability? Disability is common, like you go to the doctor, let's say you need a surgery. You go to the surgery, you are admitted to the hospital 30 days, let's say, to recover completely. This 30 days you were out of work, you weren't productive, your work might not accept 30 days or 40 days or 60 days, or there is a complication that you need to deal with. Unfortunately, nobody looks at these, and all they care about is like, okay, when are you going to come back to work? But people don't understand, okay, this is a process. This is a life a diagnosis that's affecting me every single day. And then language and culture barriers. Now you're understanding me, this is English, but some people don't express themselves in English, and sometimes we don't address these, and we let a family member talk instead of the patient, where the patient might have quality of life symptoms. We know this is a heterogeneous group. Every person is different, so every person is experiencing different side effects, experiencing different symptoms. And most importantly is the cost. And the cost starts from the time of the diagnosis, where you go to the doctor, you park your car, you have to pay a parking lot. And I always think, okay, why is my patient, I'm seeing my patient, let's say, twice a month. And this parking is costing them $10, let's say, per time. That's $20. These patients are not working, or these patients have symptoms that they are not going to work that often. And then time off work, or insurance coverages, even premiums, and then they come to the clinic, they have to pay co-payments. Why are we paying that much to healthcare? And our patients need that money and need that time to be spent at home, to be spent for food, to be spent for other activities. And that's part of the productivity, and we talked about the symptoms. And then the side effect of the medications. Let's say I give sandostatin and the patient developed diarrhea. Then I want to order Crayon because of pancreatic insufficiency, let's say. And Crayon patients come to me, the Crayon cost is $400. Like, why? What's the cost of the drug? The drug costs $1,000, but the insurance was able to cover $600, and I have to pay $400. So I think, like, how are they able to pay for this? And honestly, this is a big deal. This is part of our quality of life. And then time spent in the hospital. Patients might need to be admitted to the hospital. And this is also another time, clinic and treatment. So what do we concentrate on? Physical, psychosocial status, and emotional status. Specific illness with substantial detrimental impacts, such as pain, anemia, fatigue, sleep problems, anxiety, depression, diarrhea, heart symptoms, shortness of breath, heart failure, and treatment toxicities. If we are on Captem, hand-foot syndrome, mouth sores, diarrhea, not able to sleep, nausea from the temozoloma, which is extremely common. These symptoms, patients might not know how to deal with it, but this is affecting their quality of life on a daily basis. Then clinical factors such as the type of neuroendocrine tumor. Is it fast-growing or slow-growing? Is it a high-grade neuroendocrine tumor or low-grade neuroendocrine tumor? These are high anxiety-provoking. It differs between the type of tumor that a patient has. And, of course, functionality of the cancer that we talked about. So the limitation of these models to assess the quality of life is that if you come to the clinic, we're not going to have a paper that, do you have diarrhea, do you have constipation, do you have headache, it's not like a check mark, how much activity do you do during the day, how much sleep do you do during the day. So the patient comes to our clinic and they say, okay, I have diarrhea, which is the most important thing, let's say, today. But the patient has anxiety, and the patient has financial toxicities, and the patient has other toxicities. These might not be reflected during the clinic. And we tend to also forget about asking, how did you come today? Was it a horrible day to park in the parking lot? I talk to patients, they say, oh, I don't like to go to this hospital. I cannot find a parking spot when I go to it's a very busy hospital. So these are common things that we as doctors and as caregivers, we forget about how to think about it. And then the limitations of these questionnaires, first, it is written in English. So if we don't understand English, we're not going to assess our symptoms clearly. And then the questionnaire fatigue. If there is 100 questions, you start with the first 2, and then at the end, let's fill whatever. And then recall bias. If it happened today, it's relevant for today. If it happened last month, it's not relevant, so we forget about it. And then concomitant comorbid conditions, lack of standardized instruments, and symptom change with time. And these symptom change with time is well documented because today, as I said, and this is like a paper that was published by Arvind Dasari from MD Anderson, these symptoms change with time, but what is reported on the quality of life questionnaire is different. So how to optimize quality of life? We treat symptoms, we treat the cancer, and we evaluate treatment-related toxicities. But we always forget the financial toxicities, and we always forget the psychosocial health. How I think about treating symptoms, it is categorized also. It is either mass effect from the cancer, or secretion, is the cancer secreting hormones that is affecting the patient, or is it treatment related? And we've talked about these, flushing, telangiectasia, cyanosis, pellagra, diarrhea, and cramping. Each one has its own hormone that is affecting the pathway that makes it. And we usually tackle these in the clinic. And these are other cancers that might not have been covered, the gastrinomas, which is a neuroendocrine tumor. It secretes gastrin, it causes ulcers in the stomach, and the insulinoma, which is one of the worst cancers in my opinion, because the insulin goes up and the glucose goes down, and the patient can be confused in 1 second, or might have seizures in another second, and you keep doing whatever you can to keep that sugar up, and they put their alarm clocks on so that they wake up at night to remind them to eat, just to keep the sugar up. And this is how their quality of life is. And the vipomas is like you go to the restroom every hour, and your electrolytes go down, and then you have to keep up with the fluid, and they come and go to the hospital every other day, and it's hard. It's a hard life. And then the carcinoid syndrome, flushing, sitting with other people, I flush, then I have to feel rushed to go to the restroom. This is how Zermello works, and Zermello is a good drug, and you've heard about it. This is another version of another picture. You've seen more colorful pictures probably. And then how I think of the treatment for these symptoms is systemic therapy, because systemic therapy works, alleviates some of these symptoms. Surgery, if it is related to local effect, even debulking surgeries, and We do a lot of debulking surgery and debulking even liver-targeted therapies to try to decrease the symptoms from the cancer as much as possible. And this could be in a Y90 fashion or a TACE fashion, which are beads that go to the liver, and they are inserted through an artery. And the beads either contain chemotherapy or contain Y90, which is a form of radiation, yttrium, or they could be bland embolization, which is more used nowadays because of the PRRT planning. This is how the somatostatin receptor looks like, and sandostatin works on the somatostatin receptor. More importantly is to show you that lanreotide or somatostatin decrease the diarrhea and double if we compare it to placebo or best supportive care. And this is coming to the end of my talk. This is a paper that I published, totally different. It's pancreatic adenocarcinoma, not related to neuroendocrine tumor. And I got patients on a SEER database, and I looked like how many patients got X treatment, how many patients got Y treatment. And I want to show you this important finding. Is this? Yeah. So this is the patients, these are the patients that did not get chemotherapy. And these patients are above 75 years of age. These patients have Medicare because I linked Medicare to the SEER. And we found that 70% of patients who have localized pancreatic cancer did not get any treatment. No radiation, no chemo, no surgery. They just died of their cancer. And that raised my interest to go and seek another degree, and I did a master's degree in health law, to understand this question. Like, why are 70% of patients who have insurance not able to get any type of treatment? And I came up with many ideas in my paper, and these are transportation symptoms. They couldn't come to the doctor. They don't have access to go to a doctor. There is shortage of doctors and nurses in the periphery. You are in the city now. You don't know how patients in the periphery are feeling. They cannot come. They cannot travel for long distances. They cannot see a specialist. And the specialists are concentrated in cities, so they cannot come. And then language or culture barriers. Some people think that we don't want to touch cancer. If we biopsy cancer, it will spread, and that's a wrong thinking. And they live in denial at times, and they don't want to know. Some people don't have the money, low socioeconomic status. They don't work, and they have to go and park the car. They don't have that $10 to spend or $5 to spend in the parking lot. And employment and income losses when you are sick, you tend to not be productive, and you lose work. And then disparities by age. Oh, this patient is old. Maybe he shouldn't seek care, which is wrong. Or race, or drug cost. And drug cost, I mean, I mentioned in the title, access to care beyond insurance and beyond medication prices. We're not talking about what's the price of sandostatin or lanreotide. We're talking about what's the price of crayon, what is the price of Imodium, what's the price of Lomotil. Some people don't have that money for even $8 or $20 to pay for these drugs. And then insurance premiums and deductibles. Some deductibles are literally very high, and they don't go to the doctor because they don't have the money to pay for it. So the question remains how to close these gaps, how to move forward and think how to close these gaps and help the people who need help, and help ourselves too. And that ends my talk.